Okay. All right, so now let's go here. So now we're going to talk about sort of managing the lungs of neurologically deceased donors and sort of the hows and the whys, and this will take us up through lungs. So you all know that lung transplantation is often the only treatment for end-stage lung disease. You know that in 2022, only about 19% of deceased donors donated lungs. It was broken down into about 25% were brain-dead donors and 6%, 25% of brain-dead donors donated lungs. And really the last data I saw, this was only partway through the year, but it was about 3.9% of DCDs donated lungs. And so the DCD population obviously is an area where we potentially could make impact. We're not going to talk about that because we don't really manage DCD donors. We can make suggestions, but that's sort of where we're limited to. The limited availability of lungs leads to deaths on the lung waiting list, about 20% annually. And donor lungs are declined for numerous reasons, but most importantly, it's always the PF ratio of less than 300. And that's with a volume cycled mechanical ventilation, usually with tidal volume 10 per kilo, 100% FiO2, and a peak of 5. So what we want to talk about here is how can we increase the numbers of donors that are available or able to be lung donors. We want to contrast some of the ICU ventilator management goals with OPO goals for placing lungs for transplantation. We want to look at the impact of neurological death. We've already talked about that, but we'll just flip through those slides pretty quick on this talk. And then I'm going to show you some of the literature out there on lung donor management, and I'll share with you some of the successes I've had in a couple of other programs, including LifeBank. I mean, to me, this is the most important thing to remember, that brain dead donors are dead, and that most hospitals don't take care of many dead people on an annual basis. And so they really don't understand the physiology of managing a neurologically deceased donor. Appreciate the goals of managing a neurologically deceased donor to try to place organs versus normal physiologic kind of endpoints that they would normally look at. And so we have to communicate those things in terms of what are our goals in managing a deceased donor as opposed to a living patient. But the main goal that I have is to always get the lung transplant team to the operating room to evaluate donor lungs, because you're never going to get a set of lungs transplanted if there's not a lung donor team in the OR. And so we have to figure out how do we get them into the operating room. And that's where our management comes into play. So I just like to use cases as kind of a starting off point. This is a 26-year-old male, motorcycle collision, no helmet. So lethal brain injury, multiple fractures, lacerations, contusions, aspiration. This is day one in the ICU. He has bilateral contusions. You can see on the chest X-ray. He's in VCAC, tidal volume 6 per kilo, peak of 5, rate of 18. I time is 0.9. He's on 80% oxygen with a PF ratio of 250. By day 3, still under the care of the ICU team, he's got worsening atelectasis with infiltrates and contusions that blossomed. Same ventilator settings, except the FiO2 is down to 50%. His blood gas is 7.28 with a CO2 of 48, an O2 of 80, a base deficit of -5, and 95% saturated. And his PF ratio is 160. So if you were to interpret that blood gas, how would you interpret that blood gas, having had just an excellent lecture on how to interpret blood gases? So the pH is greater than 7.4 or less than 7.4. So that makes it an acidosis. And then we look at the CO2. And the CO2 is less than 40 or greater than 40? Okay, so it's at least a respiratory acidosis. And then you look at the bicarbonate, or do we have a bicarbonate? We have a base deficit, -5. So that's going to be a metabolic. So this is a mixed metabolic and respiratory acidosis. It's got a respiratory component and a metabolic component, right? Everybody buying that? Excellent. So on this day, day 3, the patient was underwent a neurologic deterioration, was declared deceased, and it was determined to be an organ donor. So the question is, are your respiratory goals met? And the answer is, it's all about your perspective. And so I put these nice pictures up here where you can see kind of a couple of different things in it, depending on how you're looking at it. So what do you see in this picture?
It's women playing sax.
Yeah, so there's a sax player and there's also a woman's face. So to me, it sort of depends on what the perspective is. This is the way I think about the OPO and the ICU teams. We look at things and sometimes we're looking at it from a different perspective. And so what we're trying to accomplish is a little bit different. So from an ICU standpoint, your blood gas has adequate oxygenation, adequate cardiac output, and so you're supporting your DO2. You have adequate ventilation. Your pH is better than 7.5, even though it's not perfect. 7.25, I mean, even though it's not perfect. And you've minimized the likelihood of ventilator-induced lung injury because you're using 6 per kilo of tidal volume, and your peaks are relatively low and your pips are relatively low. So from an ICU standpoint, your goals are met. You don't need to do anything more with that donor. Okay. But from an OPO standpoint, we have to place lungs for transplantation. So we need to think about what is the ideal lung donor. The ideal lung donor has a PaO2 of greater than 300 on 100% oxygen, so a PF ratio of greater than 300, on a PEEP of 5 and a tidal volume of less than 10 per kilo. Has a clear chest X-ray, no purulent secretions or aspiration on bronchoscopy, less than a 20-pack-year smoking history, less than 55 years old, no significant chest trauma, pneumonia, sepsis, or chronic lung disease. So from an ICU perspective, your goals are not met. Okay? And again, this is another one of my perspectives. What do you see in that picture?
Jesus.
You see, it's easy. You see Jesus. That's lovely. Bless your heart.
He's been working on me.
Yeah. Okay, so you can see a man in a sombrero riding a horse,
Oh,
and you can see an old man face on the sideways. The horse is riding towards you. You can't see it. So again, this reminds me we all have differences in our perspectives when you see things and you don't. So OPO goals are ideal lung donors are very rare. We know that. We know that extended criteria donors, which the majority of our donors are smokers without emphysema and or chronic lung disease. They have trauma with or without chest tubes. They have aspiration, but as long as it clears on an early bronchoscopy and it doesn't refill, then those lungs potentially can be transplanted. Some of them have PF ratios of less than 300 and they can be transplanted. They can have bacterial infections, as long as they're on appropriate antibiotics for an appropriate duration of time. But this all requires communication with the accepting surgeon and the specific donor and a specific recipient. And the data says whether you use an ideal donor or an extended criteria donor, when you look at recipient outcomes, they're exactly the same. Okay, so this tells us we can use these extended criteria donors. So back to our donor, what do we do now? We go to the OR and recover liver and kidneys because the lung function is bad. We increase the FiO2 to 100% to increase the PaO2. We increase the ventilator rate to improve the respiratory acidosis. We begin lung recruitment maneuvers, or all of the above.
All of the above.
D. Yeah, I'm not on the operating room.
Do it all.
No,
I'm kidding.
you gotta, sometimes you gotta slow your roll when you work.
Yeah,
with
for sure.
Sometimes
I
you gotta
have
slow
to.
it. You do, because if you take your time, you're gonna end up turning more organs around, you're gonna end up donating more organs. But it does take some time to do this stuff. It can't happen immediately. I mean, we take these donors over after a number of days in the ICU, and we need to have our time. So what I would say is you want to begin your lung recruitment maneuvers. Does increasing your FiO2 to 100% increase your PaO2? Yes, but does it increase your PF ratio? No.
And
you don't-
increases your risk of damage.
Well, we'll talk about some of the issues with putting somebody on 100% oxygen for too long. We already talked about the potential for oxygen-induced toxicity, but there are other more immediate issues that we'll talk about a little bit later. So begin lung recruitment maneuvers. So how many of us have had formal education on in vivo rehabilitation of lungs in a neurologically deceased donor to maximize transplantability of organs?
There should only be 3 people.
Everybody took a course of that in medical school or nursing school or respiratory therapy school, didn't you? No.
Yes, it's good.
None of us. So the answer is none of us. What we do is we use our ICU knowledge combined with our own experience in managing donors, and we try to base it on sound physiology. So our goals are to try to optimize lung function and minimize the injury to the lung. So we want to provide adequate oxygen delivery to support all of the organs in the context of a multi-organ recovery. But we also want to increase the likelihood of lung recovery for lung transplant by trying to get a clear chest X-ray, minimal secretions, and a PF ratio of greater than 300. So why do donors have suboptimal lung function? Well, there's a bunch of reasons. Either there are pre-existing factors because they have asthma, they smoke, they have infections, or they have a cause of death related issue, like they aspirated at the time of death. They had contusions from trauma or fractures from trauma. They developed pneumothoraces, or they had infection. Or the head injury causes pulmonary edema, neurogenic, Or they can have ventilator-induced injury or infection, depending on how long they've been on the ventilator and how they've been treated by the ICU setting. And then there's the brain death physiology-related things, including the apnea test, where you're completely removing them from positive pressures, and you're basically putting them on flow by oxygen, which leads to what? Lots of de-recruitment and atelectasis. And then there's also donor management-related things that we do pre and post declaration. We talked about the catecholamine storm. I'm not going to go over that again. But the other issues that patients that are brain dead have is they don't have any spontaneous respiratory effort. You know, when we're all sitting here breathing, what do we move in terms of tidal volume? When you take a tidal volume breath, just sitting here comfortably under no stress, you know, what kind of tidal volumes are you moving in terms of cc's per kilo based on ideal body weight? 4? Yeah, somewhere between 3 and 5 per kilo. Now, when you take a big yawn, how much are you moving then?
8, 9.
Maybe 12 or 15 per kilo with a big yawn, right? And that's what we do. We have sigh breaths that open our lungs up every now and again. And we all do it all the time, especially during boring lectures. But not that this is one. But this is what keeps our own lungs open. All right. But we don't, in brain dead patients, they don't cough, they don't sigh, they don't have any movement. And this leads to hypoxia, atelectasis, and plugging. On top of that, most of our donors have some kind of aspiration during the CPR process. I mean, how many of them don't? It's pretty unusual. And then they develop pulmonary edema that can be neurogenic, vasogenic, or cardiogenic in origin. Remember that there is the inflammatory response that occurs with the brain death process. And people used to think that donors had ARDS all the time. But the fact that we can turn these lungs around in 24 hours or 48 hours says this is not ARDS. ARDS takes weeks to resolve. And so it's a very, very small percentage of our patients, probably less than 10, that actually have ARDS or some kind of inflammatory component that causes primarily lung injuries. We also know that brain dead donors have decreased CO2 production. Do you know why?
Decreased metabolism,
Decreased metabolism, specifically of what?
skeletal muscle,
Brain,
skeletal muscle.
brain.
Well, the brain. So the brain metabolizes glucose, and glucose breakdown is CO2 and water. And so because your brain's not working anymore, you probably are producing somewhere along the order of 20 to 40% less carbon dioxide, just based on the fact that your brain's not working anymore. And so we can not have to ventilate them the same way we would ventilate a living person. They don't need as much minute ventilation in order to maintain a normal pH and normal CO2. All right, so how do we overcome these issues to provide adequate oxygen delivery and try to maximize the potential for lung donation? Well, ideally, we want to try to get normal ventilation and oxygenation. We want our pH to be 7.35, sats 4.5, CO2s in the mid 35 to 45 range, and sats greater than 95%. We want to limit the ventilator-associated complications. We talked about oxygen toxicity, pressure injury, and volume injury. And we want our PF ratio to be greater than 300, P/5. So how do we get there? Well, there's no really one ventilator mode that's been ideal. And the practices are historically diverse. They're usually based on local OPOs and local lung transplant program biases. And this is either from the pulmonologist locally, or the surgeons locally, or the OPO medical and procurement directors locally. But the key is getting the lung transplant team to recover them to look at the lungs. And I like to say that the literature is sparse, but the opinions are abundant. So everybody has an opinion as to what they think is the best. But this is the way that I think about it. My mindset, all donors are lung donors until they're proven to me that they're not. And that means that I try to do alveolar recruitment strategies with my goal of being a PF ratio of greater than 350. Because if I can get greater than 350, then I can talk most surgeons into coming to the operating room for 300, they may or may not, but 350, they're coming. We want to avoid ventilator toxicities. We want a clear chest x-ray, and we want a good bronch. And so if we look at maneuvers you can do with a ventilator, probably the best recruitment maneuver you can do with a ventilator is CPAP. Just straight CPAP at 25 or 30. We know that. There have been studies that have done that, and that's great, but you also need to ventilate patients, so you can't do straight CPAP. So you can do CPAP and sign maneuvers. You can do volume control with a high peak. You can do pressure control inverse ratio ventilation, or you can do what I call extreme pressure control inverse ratio ventilation, which goes by the name of either APRV or bivent, bilevel, or other names depending on the ventilator company, or the high frequency oscillator that we alluded to that we're never going to do. You can do early and repeated therapeutic bronchoscopies to try to eliminate any kind of plugs or mucus or aspiration. And you want to do this with the minimal amount of saline possible, because you don't want to flood the lungs anymore. You can use albuterol or mucolytic agents, chest physiotherapy, suctioning, and positioning, including proning, which you know, since the whole COVID thing has become much, much easier to do. You guys prone a lot of your donors now? I mean, because the hospitals are willing to do it now, where they used to, you know, they used to fight you tooth and nail to prone people, and now they all have prone teams from taking care of COVID patients, and they don't think twice about proning people. And so I think we really don't take nearly as much advantage of proning as we should, and I think it is an effective mechanism. And then we can use some adjuncts like corticosteroids. I have thyroid hormone listed here. Maybe, maybe not. The study's being done and the results are coming out. We'll see. And then fluid status, you want them to be at least euvolemic. You certainly don't want them to be volume overloaded. They may end up being temporarily volume overloaded because of the lack of vascular integrity and a few other stuff. So they're going to be third spaced a little bit, but we want to just keep an eye on them. We want to make sure we're using diuretics, and loop diuretics are very common. This is an old paper on just using PEEP for recruitment. Oh, no worries. We'll see you later. The PEEP is in the left upper corner is on a PEEP of 5. And what they did in this study is they looked at CT scans and they looked at the area of collapse and the mass of collapse based on the colorimetric changes on the CT scan. And they showed that if you put somebody to a PEEP of 19 and you leave them there for a little bit, you can drop that mass significantly. If you go up to 25, you can completely eliminate both the areas of alveolar collapse and you can eliminate the mass that's collapsed to the lungs. And then if you turn their PEEP down to 23, 30 minutes later, you can also see that it maintains itself. So this is just showing that CPAP is an effective maneuver for trying to recruit lungs. What we do know about recruitment maneuvers is that suctioning causes de-recruitment. Remember, every time you put a suction catheter in and you're sucking air out, those lungs are collapsing. And so if you do it with an open suctioning where you lose all of your PEEP or all of your mean airway pressure, it's much worse. So we try to avoid that. You can do side and sustained CPAP maneuvers, but remember when you do that CPAP 20 for 20, 25 for 25, 30 for 30, if the patients are already on high PEEP, you can cause significant overextension and can actually cause problems. And then the other thing is all of these maneuvers that you're doing for recruitment can also increase your intrathoracic pressure, which, as we talked about before, can not only lead to barotrauma, but can decrease your cardiac output because it decreases the venous return, and therefore you end up with tissue hypoxia. So back to our donors. The OPO consults with the ICU team that's been caring for the patient, and they decide to change the patient to pressure controlled ventilation, increase the PEEP to 10, increase the I time to get a 1-to-1 ratio, and order a bronchoscopy. You wait 4 hours. The blood gas now has a pH of 736, a CO2 of 36, a PO2 of 90 on 60%, bicarb of 19, and base excess of 4. So what do we do now? Well, now we have to sort of see what else we're going to do to recruit. So this is a paper that came out in 2010 out of Europe. They did a randomized control study at 10 European centers. Group 1, they put on a conventional tidal volume of 10 to 12 per kilo, a PEEP of 3 to 5. They did open suctioning and they did an apnea test off of the ventilator. Group 2, they put on 6 to 8 per kilo of tidal volume, a PEEP of 8 to 10, closed suctioning, and did the apnea test on the ventilator with CPAP. And what they found is that from Group 1, 54%, and from Group 2, 95% met criteria for lung transplantation. And they actually transplanted 27% from Group 1 and 54% from Group 2 were actually used, and the 6-month survival was identical. The results of this study is most people went away from using high tidal volumes, low PEEPs, and went to using moderate tidal volumes, high PEEPs as their recruitment maneuvers. And in Europe, at least, they don't take patients off the ventilator anymore to do apnea testing. They keep them on CPAP. And they found that to be extremely helpful because they never have that de-recruitment. And so some of us have been pushing to do the same thing in the United States here.
How much CPAP do they put them on? Just like
10, just leave them on 10 or 12 or something like that, just so they don't de-recruit.
Okay.
But you have to have a respiratory therapist that knows how to stop the ventilator from auto-cycling.
Yeah.
Yes.
You just have to keep retiming it.
Yeah.
Until they get to the end. The San Antonio Lung Transplant Program, the SALT study, published this in 2006. And this is where this was Luis Angel or Angel from San Antonio. He's a transplant pulmonologist. So he said the key features of this where you get a transplant pulmonologist involved. You do recruitment maneuvers, keep the patient hypovolemic with diarrhea or euvolemic with diuresis, and you prevent aspiration by putting the head of the bed up 30 degrees. You inflate the cuff to 25 millimeters, and you do bronchoscopies. And then their approach was you do PEEP of 15, pressure control of 25 for 2 hours. then a tidal volume of 10 per kilo, then a PEEP of 5, and then you get your ABG. And what they showed is that they could improve in their pre-salt study management from 11.5% of their donors donating lungs to 25% of the donors donated lungs. And their initial poor donors, which would not have donated lungs prior to doing this, actually were 53% of the donors that donated. The 30-day and 1-year graph function outcomes were identical. This was another multi-center study done in Europe by the same group that did the first study. This was in 2015. They did this study in 6 Spanish hospitals, and they did this with all donors. They did the apnea test on the ventilator with PEEP. They did mechanical ventilation with PEEP of 8 to 10 and a tidal volume of 6 to 8 per kilo. They did recruitment maneuvers with a PEEP of 18 to 20, plateau pressures of 35 for 1 minute, then decrease the PEEP by 2 each minute, then increase the tidal volume by 50% for 10 breaths every hour. And they did bronchs with alveolar lavage immediately after declaration. And they used a PICO system, which is a minimally invasive monitoring system that helps you look at your extravascular lung water. And with that, they regulated it so their extravascular lung volume water so that patients were appropriately diuresed, bottom line. And they wanted their CVPs to be less than 8. A little bit of a labor-intensive protocol. But what they showed is that their lung donor numbers doubled from 13% to 27%. And the numbers and the number of transplants doubled as well. And there were no differences in the early recipient survival or the rate of primary graft function. And so they said implementing a standardized intensive lung donor protocol increases lung procurement without detriment to early graft survival. This study was done out of St. Louis and published in 2018. This is where they said lung-focused resuscitation in a specialized donor care facility improves lung procurement rates. And the key features here were they transferred the patient to the donor care facility very, very quickly. And they used the 6 to 8 per kilo tidal volume, IDE of 1 to 1, PEEPs of 8 to 10. They would either use volume control or pressure control and kept their PIPs less than 30. Their PF ratio then determined what they did next. If it was greater than 300, they just left them as is. If it was less than 300, they increased the PEEP to 15 for 2 hours, increased their percussive ventilation, chest physiotherapy, and their turning. They repeated the bronchoscopies, and then they used ultrasound to evaluate the lungs for water and edema, and based on that would decide whether they needed to be diuresed or not. They also used minimally invasive hemodynamic monitors and targeted their pulse pressure variability and stroke volume variability. And what they showed was they could increase their lung procurement rates from about 20%, which was the average for the nation, to up to about 34%. And the implantation rates of both groups were fine. They were about the same. And there were no differences in any of the other organs transplanted. And they showed that their overall organs transplanted per donor went up from 3.5 to 3.85 when they did their lung donor management protocol. And their conclusion was a focused lung management approach led to a 71% increase in lung procurement rate with equivalent transplant rates in both groups, and that the specialized donor care facility was thought to be a factor in this implementation. And then this study came out in 2018 from Europe. And basically what they did is they did a meta-analysis looking at any articles on lung donor management protocols versus no lung donor management protocols and looking at outcomes. And what they said was they tried to compare the regimens of treatment during all these protocols, but they were so different that they couldn't do that. So they just compared the odds ratios of recovering lungs if you were managed with a protocol versus no protocol, and said that if you implement a lung management protocol, you improve your transplant success rate, which inherently makes sense, right? You do the same thing every time, and it's a logical thing. You should get better and better at it. So what are the other ventilator options? Well, the other ventilator option that I look at is APRV, or extreme pressure control inverse ratio ventilation. In reality, this is really a pressure control mode of ventilation. APRV is really designed to be a mode for spontaneously breathing patients. That's not what we do because our patients don't spontaneously breathe. But that's what APRV is really designed to be. But in order to be able to get an inverse ratio beyond about 3 or 4 to 1, you have to use a different setting than pressure control on any ventilator. Otherwise, you can't do it. It locks you out. So you have to either use the APRV mode, the bilevel mode, the bivent mode, the biphasic mode, depending on what company's ventilators you're using. And if you can't do that, then you try to use pressure control and try to get your IDE out as far as you can, but you can't drop your P low or your peak to 0 because your expiratory time is too long and you're in deep recruit. So with APRV, don't think about it as APRV, think about it as pressure control in inverted ratio ventilation extruding. And really what you can think about it is a CPAP with occasional breaths. Because you can get away with a low rate because you just need to ensure adequate ventilation. We already talked about why brain dead donors produce less carbon dioxide typically. And then what we see happen in this mode is as recruitment occurs, the tidal volumes start to climb. And whenever the tidal volumes start to climb above 9 per kilo, then you just start backing down on your P high. And so it's an automatic recruitment mode that you just have to pay attention. This is a graphic of the difference between looking at a spontaneously breathing patient in the top graph where you can see these small breaths that occur. That's where a breathing patient, a living patient will augment their minute ventilation by spontaneously breathing. The bottom graph is a brain dead patient or a neuromuscularly blocked patient where they have no breaths. Okay, and that's essentially what we're doing. So that's why I say it's really not an APRV mode because they're not getting any supplementation of their minute ventilation with their spontaneous breaths. Now, what are the contraindications of this mode? Well, hypotension or hemodynamic instability is going to be one because you're increasing your mean airway pressure so significantly, you're decreasing your venous return. So you've got to make sure these are volume loaded patients. You got to volume load them, okay? Untreated pneumothoraces, unilateral lung disease, severe asthma or COPD, and any donor that requires prolonged expiratory time that appears to be having severe obstructive disease, and anybody with a large bronchopleural fistula additionally. So what are the advantages? That you can improve oxygenation by increasing only your MAP, and you can do that without increasing your PIP, so you put them at less risk for barotrauma. And you're controlling your tidal volumes, so you're putting them at less risk for volume trauma. And so you get away with a higher mean airway pressure, less risk of barotrauma, less risk of volume trauma, and you can wean your oxygen down so you don't have oxygen toxicity. In addition to that, you don't have to continue to do recruitment maneuvers because this is a continuous recruitment maneuver and it's in and of itself. You have lower minute ventilation, which equates to less ventilation to dead space, and you recruit collapsed alveoli, and for neurologically deceased donors, that means you're almost doing constant recruitment. Potential disadvantages and risks are the tidal volume will vary depending on changes in the compliance and resistance. So you have to pay attention to the tidal volume when you're in this mode. And the nurse at the bedside has to pay attention to the tidal volume or you can end up in trouble. You can potentially get over distension if you don't pay attention to your tidal volume that can lead to barotrauma and volume trauma. If your T-low is too short, you can produce too much OP, which can be no good in patients with obstruction. So you want to use it in caution with patients that are hemodynamically unstable because you can impede the venous return, which can decrease your cardiac output, which can decrease your blood pressure, urine output, and all of your delivery to your vital organs. Okay, so how do you initiate pressure control and respiration and ventilation on a donor case? And everybody has a different style to doing this, but I'm just going to share with you what I do, and you can go from there. If you have questions, again, stop me and ask. But you check your PIP on your prior pressure control settings or your plateau on your volume control mode, or you can take your desired map and add 3 to it, and that's where you set it. It should be greater than 20, but less than 35. And you're going to make adjustments to actually not only increment your map goal, but also the increment and to get the delivered tidal volume you want, which is going to be 8 per kilo based on ideal body weight for your donor. Your release pressure is going to be set, or your P-low is going to be set to 0. When the T-low is short enough, you still have auto peep, so you don't de-recruit. And that's why it's important that you know what your P-low is. And you know also, we'll talk about it in a second, but you need to know what your exhalation rate is, pressures are. And then T-high, you want to do your inflation time. And usually you're going to set that around 2.5 to 3.5 with a T-low of 0.5. So if you have a T-low of 0.5 and a T-high of 3.5, that's going to be 4 seconds for each cycle. If you divide 60 by 4, that's going to give you a respiratory rate of 15. And that's where that number comes from, because most people in APRV should not be on a rate of much more than about 15, because you lose a lot of the advantages of the ability to maintain that higher mean airway pressure when you take their rates up too high. And they tend to air trap, which puts them at higher risk. Okay. If you have to, you can start out with a rate of 20, and that's why you can start at 2.5. But my typical starting is T-low of 0.5, T-high of 3.5, and that gives me a rate of 15. And again, the way you calculate that is it's 60 divided by T high plus T low gives you your rate. So 60 divided by 4 is 50. If I did my math right, you can double check. Clearly you need to. Okay. All right. Questions about any of this? So if you're working with a pediatric patient, we generally will use lower T lows than 0.5 because pediatric patients generally breathe a little bit faster rate. So we'll go down to as low as 0.3 or 0.4 to start with. We can go as low as 0.2 in infants, but we generally don't do that in adults. Adults, I usually don't go below 0.5. I usually find that if you go much below 0.5, you're going to get yourself into trouble. Next, you have to look at your peak expiratory flow rate. And I wish I had one big one, but I'm going to walk back and forth. So this is, all right, so forget these lumps because that's spontaneously breathing, okay, which we don't have. But I want you to pay attention to this PEFR. Now, you remember the time flow curve from before where you exhale and you come all the way back up to baseline? That's that dotted line. That would be the normal time flow curve at the end of expiration. But you don't want them to fully expire in this mode because you want to use this air trapping, a little bit of air trapping to maintain an auto peak. All right. But you want this to be set at about 50% of the total expiratory flow rate. And that's going to give you somewhere in the 40 to 50% rate tells you that you've got your T low set at the right time. And that will be the one thing that may cause me to vary my T low from 0.5. Okay. Because if my T low of 0.5 puts me over here, that's too much exhalation. I'm going to shorten my T low to 0.4. Does that make sense? So you've got to be in that 40 to 50% PEFR rate. Okay. Questions about any of this? Okay. Now let's see if this works. Yeah, sorry, we have to. How do I turn this volume?
Are you trying to?
Skip ahead.
Hurry, Melissa, we're missing a commercial.
Okay. So this is a set of rabbit lung code. Can you do this? I'll go look at the picture. So this is a YouTube video that looks at an isolated pair of, I think it's rabbit lung. Okay. And if we can get it to work. Working on the computer. Hang on. Oh, there you go. Okay. Now, perfect. Can you start it back at the beginning? There you go. Okay. So this is a set of lungs, and they're trying to recruit. And if you look at this I to E ratio, you'll see that it's about a 5-to-1 or 6-to-1. And you can also see that as they stay in that prolonged inspiratory phase, the mean airway pressure stays high. You get elimination of more and more of the alactatic changes in these lungs. Okay, until you get to the point where they're fully expanded and absolutely beautiful, and these are transplantable lungs, right? And this is the beauty of a prolonged I to E ratio, right? So this is like a 5 or 6-to-1 I to E ratio. And by doing that, you can get away with much lower peak pressures and much higher mean airway pressures and do really nice recruitment. Okay. So I think it's just it's a nice, now what the other thing it shows you is that once you take away that pressure, they de-recruit almost immediately. You know, and so my concern is when I have somebody that's in this mode of ventilation, and I talk to a lung transplant center that says, I want you to put them in a volume control mode. I want them to be on 8 per kilo of tidal, 6 per kilo of tidal volume and a PEEP of 5. And I want you to leave them there for 3 hours. Then I say, I'm not going to do that. Because I know the physiology tells me that in the milieu of a dead person's body, those lungs will completely de-recruit if I do that. What I agreed to do and what we've done, now I got to find my spot. You go. Wait a minute. There you go. So what I do is I tell them that I'll do it, but I'm going to do it for half an hour. And then I'll get a challenge gas, and that's what I make my offers off of. And in fact, I don't even usually ask them. I usually just get my challenge gas, make my offers, If they're not willing to accept or they want me to jump through a bunch of hoops, I just say, thank you, but no thank you, we'll pass and move on. Because we'll place these lungs with somebody. If my PF ratios are good, on my challenge, yes. Okay. So this is a couple of the papers that actually looked at APRB in organ donors, neurologically deceased. This was an early paper in 2011 where they took 35 consecutive donors in Michigan. They did 20 of them with assist control and 20 of them with APRB. The APRB were slightly younger. The APRB PF ratios were almost 500 compared to the ACV of 334. The APRB group, 42 of 50 were potential lung donors versus 7 of the 40 in the ACV group. And the graft survival was at 1 year and 3 year comparable to national averages and no different from each other. This was a study where they took 9 brain dead donors and they put them all on CMV and they changed them to APRV mode. They didn't change the FiO2. They did a p-high to achieve a tidal volume of 6 to 8 per kilo like we've talked about. And all of the patients demonstrated increases in PaO2 with an average of a 37% increase in the PaO2s. 6 of the 9 patients donated lungs that were transplanted. 9 of the 9 met their PF ratio target of greater than 300, but 2 of them were excluded. 2 of them because they were on a vent for more than 3 weeks, and 1 had a bad aspiration event. In addition to that, there are the adjunct strategies that we can use, like steroids, bronchodilators, albuterol. But remember that the BOLD study that was done out of whatever the San Francisco OPO's name is now, Donor Care West, I think. Donor West?
Donor West, yeah.
Yeah, thank you. I know they changed their name, but Donor West did a study before they were Donor West where they looked at albuterol to see if it would make any difference in their lung outcomes, and it did not make any difference if they did lots of albuterol. Most of us will do albuterol every 4 hours, but we won't do much more than that. Makes patients tachycardic, they drop their potassiums, and they can develop a metabolic acidosis from too much albuterol. Lactic acidosis, which then you're going, why do they have lactic acidosis? And usually it's because they've been pounded away with albuterol. The other thing is chest physiotherapy with repeated bronchs, vest therapy, position changes. Prone positioning has become a much more important issue lately. We have the mucolytic therapy that you can use, either Mucomist is the typical one people will use. And then obviously the ex vivo lung perfusion has brought in a whole new aspect of it. And the newer proposals are looking at actually in vivo perfusion of the lungs, right? Putting them on a bypass circuit in the body for a while in DCDs anyway. And that may have some implications too. So in terms of prone positioning, and this is where this slide show is not up to the snuff on the new one, but there was a paper that was done by Gary Martland and the group in St. Louis where they prone positioned their brain dead donors, and they showed that it acutely increased oxygenation and resulted in more lungs transplanted. They did 27 donors at the donor care facility. They were 12 to 70 years old. They had bibasilar atelectasis on chest X-ray or CT. Their PF ratios were less than 300. Their baseline PF ratios were 222 in the study group and 187 in the control group. 4 hours prone, they showed a change up to 348 in the prone group and 264, which was a change of 102 versus 54. And 12 hours prone, they were able to show that their prone group had PF ratios of over 350, where the control group had PF ratios of 280. And they showed that they could transplant 52% of the lungs from the prone group, 23% of the lungs from the control group. And this was just proning. They didn't do anything else differently. And this to me is a really strong study that really says we ought to be proning pretty much every donor. Yeah.
So are they proning them like at the beginning of their case or
So
like?
they prone them from the get-go. They
Okay.
prone them 12 on, 12 off, if I remember the study correctly. So they flip them every 12 hours.
Interesting.
And they were able to show those kinds of changes. Those changes were only within 12 hours. though.
Because I think that, I mean, I hate proning people like everyone else does, but I do think that that's something that we do like as a last ditch effort instead of doing it.
Yeah, so I think that's a mistake. I think
So,
probably doing it earlier.
yeah.
I think if you do proning in combination with APRV and really aggressive mean airway therapy, it's going to have a much more dramatic effect much quicker. And I do think there is a role for early proning in donors in this day and age.
I just don't think it's something that we've really talked about like as a group.
Yeah,
Well enough.
Is this like, this
mine lately have been super unstable, that proning is absolutely not an option. Because when they code, it's like, well, they're prone. That takes a minute to get, the ward in. And so
Correct.
now I've lost all of.
So
the
yeah, obviously you
warded
have to try to
person.
make sure, I mean, you have to set your patients up for proning appropriately. They have to be relatively stable.
Right,
And you have to anticipate that they may have instability during the proning and be prepared for some of it. But again, if you have patients that are really, really unstable, you're not gonna do that. But that's where you can get away with doing the APRV because you don't have to move them. And you don't have to really do much to them. You just put them in APRV and see what happens. But it's not gonna be as successful as if you prone them.
Okay.
All right, so this is what we did at LifeBank in 2009. We implemented a lung donor management protocol. We reviewed everything we were doing. We looked at our own numbers. We reviewed the literature. We talked with high-performing OPOs, and we tried to figure out what we wanted to do. We talked with some ventilator experts. Then we talked to our local lung transplant program, and we developed this aggressive lung management protocol. And then we educated everybody as to what we were going to do. Our mindset was all donors were lung donors unless they had chronic lung disease or they died secondary to an asthma attack. We initially changed to pressure control ventilation, as we talked about. We target 8 cc's per kilo of tidal volume based on ideal body weight. We take the IDE to a 1-to-1. We increase the peak from typically 5 or 6 or wherever it was to begin with up to 8, then 10, then 12 as they tolerated hemodynamically, and then we kind of wait there. A lot of times we have to volume load them initially in order to get them to tolerate that, which is okay. We usually give them 500 to a liter of volume. We get our minimally invasive monitor hooked up. And we use either stroke volume variability or pulse pressure variability somewhere in the 8 to 10 range is what we target our percentile. That's just what we found with donors. It's a little different than what they have in living patients, but we find that donors need to have a little bit different numbers. And then we wean the FiO2 as low as we can because we know that if you keep patients on 100% oxygen or high amounts of oxygen, they will develop oxygen-induced atelectasis. And so that hurts you over time as well. So we try to get them down as close to 21% if we can. If I can get them to 21%, as long as their sats are greater than 94, I'll keep them at 21%. But if I need them at 25%, I'll do that. I'll put them at 30%, but I try to get them as low as possible to minimize the risk of having atelectasis. And then we do blood gases every 4 hours, chest x-ray every 12, early and repeated bronchs as needed. And then we do our chest physiotherapy. And then any subsequent changes are driven by our PF ratios. And our goal is if it's greater than 350, we hold where we are. If it's not greater than 350, then we continue our recruitment. We pay close attention to our hemodynamic stability. If we need to give a little extra volume, we need to. We know that when we put patients and raise their mean airway pressure up to 20 or 22, they're going to need more volume. We just know that. And then what we do is at the end, when we get ready to go to the operating room, we'll give them a big slug of Lasix about 2 hours before they go to the operating room. That way, when they get to the OR, the lungs are not foggy when they go onto an anesthesia machine, if they're going to convert them from our recovery settings. We prefer to keep them on our recruitment settings in the operating room and in our own donor care units. That's what we do. But once they open the thoracic cavity, then we of course turn them down and get them back down to conventional ventilator settings with lower volumes. Otherwise, they just do this. We don't want that to happen here.
On your chest physiotherapy, do you guys do more like the Metanev invasive?
We typically do vest.
Okay.
And just repeated bronchs, but Metanev also, there's some good data on that in the ICU population. I have no problem with using it. We just never bought one. If the PF ratio is less than 350, then we start switching over to an inverse ratio ventilation. That depends, of course, on whether they tolerate an IDE of 1-to-1. If they can't reach end expiration on that time flow curve, we don't flip over. But if they do tolerate it, they do reach end expiration, we'll go into a 2-to-1. Sometimes we have to drop our peak from 12 down to 10 or 8 when we go to a 2-to-1. That depends on whether they're able to reach end expiration still or not. Once we're there, if we're still not getting PF ratio greater than 350, then we flip them over into an APRV mode or a bivent mode or an extreme inverse pressure control mode out to usually a 5 or 6-to-1. So we'll do a T low of 0.5 and a T high of 3.5. Again, if your rate is too high, you cannot do it. If your rate's above maybe 18, you can't flip backwards. You can't go into an inverse ratio ventilation. And what I usually tell people is if you're on a rate, if you have an adult donor and you're on a rate of more than 20, there's something wrong with the way you're ventilating. I mean, you need bigger tidal volumes, your height measurements are off, you need to change your PEEP around a little bit differently, but there's something not right. If they need more than a rate of 18 or 20 to be able to ventilate appropriately, you're going to be in trouble. And you're not going to be able to flip them over, and they likely won't be able to go there. And then if they're still not getting that PF ratio greater than 8 to 10, I'll take them out to it, or greater than 350. I'll take them out to an 8 to 10 to 1 or 12 to 1. I've had somebody up at a 15 to 1 for a while. As long as they're ventilating okay, I don't care. And then we maintain our hemodynamic stability, and we make sure that we have adequate volume resuscitation as the mean airway pressure increases, but we try to avoid volume overloading. So we use our minimally invasive monitors. And then we maintain that lung recruitment. We avoid lung injury. We maintain the lowest FiO2. We do all of our closed suctioning, prone positioning. Usually we're into APRV, or we're getting our PF ratios above 350 by the first 4 to 6 hours being on site. And if we're not there, then we're in APRV by 6 hours out. Okay, so that's how we do it. And that way we try to get our donors in the best situation we can as quickly as possible, because we usually have a limited time frame. And then anything we do, we'll try to avoid de-recruitment. So if we have to go somewhere, we'll try to use our transport ventilator. We'll try to keep them on their recruitment settings. The only time I'll take them off the recruitment settings is when we're doing our apnea or we're doing our blood gas challenges. And I'll usually try to coordinate doing an echo at that time, because it's hard to echo somebody when they're in an inverse ratio 6 or 8 to 1, because the windows are really poor. They can't see through those big inflated lungs with the ultrasound transthoracic. If you can't do it, sometimes you have to end up doing a transesophageal echo. Questions about any of that? So then after we get our, sorry.
I was gonna say, so when you guys do fluid resuscitation, what is your fluid of choice?
It depends. I'll use crystalloid, normal saline, until I have an albumin that's less than or equal to 2.5, then I'll use 25% albumin. I don't use a lot of 5% albumin. I use 25%.
Yeah.
That's just me. I do it because it's less volume for my buck. And like I said, most of these donors are third spaced. They have fluid laying out in the tissues. And so I try to use the 25% albumin to bring some of that fluid in.
I think a lot of times we're putting too many fluids in our patients, and then we're kind of like catch up.
Well, but that's where, if you use your hemodynamic monitors, though, you shouldn't be doing that.
Yeah, but a lot of ours are dry.
The patients are.
Yeah.
But there have been a number of people that have looked at that and show that you've got to volume resuscitate them first.
Right,
They don't
yeah.
do it.
I'm just saying, slamming in 6 liters into someone and then let's try to get lungs isn't the best option.
Challenging.
That's what I'm saying.
I would say also not dumping in a bunch of half normal.
Yeah.
As
Well,
well.
so I think that for acute volume resuscitation, initially I'll use normal saline. But if their sodiums are creeping up, I'll switch to half normal. I'll put them on half normal as my maintenance fluid, or quarter normal. And then I'll turn my rate up to, 250 an hour or 500 an hour, and I'll resuscitate them more slowly. But when you're going into APRV mode, you can't do it. You've got to volume resuscitate them, or they won't tolerate it hemodynamically. And then you're hurting yourself in terms of your ability to do lung recruitment. So then I'll use either 25% albumin. And I'll use that always. When I give albumin, I always give an amp of calcium. So if I give 25% albumin, I give an amp of calcium chloride, because I know it's going to drop their ionized calcium. And instead of waiting to get the labs back, I just give it to them automatically. It's really hard to make somebody hypercalcemic to the point where it's injurious to them, especially in brain dead donor. So that's what I do. Let's see. So then when the lungs are maximally recruited and I get 2 PF ratios of greater than 350 on my recruitment settings, whatever they are, then I'll do a challenge gas. And that's the challenge gas that I make offers on. If my PF ratio is greater than 350 on that one, I'll make my challenge gas. But I'll leave them on the challenge gas settings for only 30 minutes, no more. I'll put them on a pressure control mode of ventilation, IDE of 1:1, PEEP of 5, time volume of 8 to 10 per kilo based on ideal body weight, depending on their body habitus. If they're really heavy, I'll try to go 10 per kilo. I don't like doing it, but I'll do it. And I may do the PEEP up at 8 instead of 5, but generally I do because UNOS requires it. So I'll do my challenge gas, and as soon as that gas is pulled, I don't wait for the results to come back. I put them right back on my challenge gas settings, because I don't want to de-recruit any more than I possibly have to. Okay.
How much Lasix do you give them for a lot?
So it depends on the donor and whether they've gotten Lasix before, but if I think they're significantly, if I get them in APRV mode, I think they're pretty significantly volume overloaded, I'll give them usually somewhere between 60 and 100 of Lasix.
On your brain dead donors?
Yeah, right before, 2 hours before the OR. Because that way, because I don't want the lungs to be boggy when they're in the OR.
Right.
A lot of the surgeons that I've talked to from the transplant centers want them to be 1,000 or less, on their fluid. If they're,
On their balance.
yeah, if their fluid balance.
Well, okay, so first off, fluid balances don't mean jack, because nobody keeps a good calorie.
That's a lot of them, they're like, what's the
Yeah,
fluid
they
balance?
do.
And I'm like.
What you do is you say, listen, we don't really feel like the fluid balance is adequate. We use a minimally invasive hemodynamic monitor to determine whether they're fluid responsive or not. And we run it at this percentage. And we will always give them diuretic before they go to the operating room. And the reason I do it an hour or two before is because I want them to have that response to the Lasix in an hour response. And then they go to the OR, and look, if they're in the OR and their pressure starts dropping a little bit, they can give them extra volume in there. But at least we've got them in a situation, because I can tell you, if you have somebody in an inverse ratio of 6 or 8 to 1, you've pretty much squeezed all the water out of their lungs, and it's everywhere else. But as soon as you drop that and put them in on an anesthesia machine with an IDE of 1 to 1, their lungs just flood. And so that's why I do that a couple hours before. That's just been a routine practice.
So you start with 60. We're
Well,
gonna second
again-
dose if it's not, if they're.
So if they don't have a response within an hour, then I give a second dose.
of
So
60,
that's why I
yeah.
give them 2 before, like I start 2 hours before. I give them a dose of Lasix, big dose. And then if they don't have a response, now if they've never seen Lasix before, I may only give them 40. Okay, but I'm gonna give them something that's gonna be relatively substantial, because I know that by the time I convert them over and they're in the operating room, they're not gonna be dry as a bone. I know that. And they're gonna have a little bit of wetness, and I don't really want them to have wetness if they can avoid it. So that's at least my approach.
So would you also give albumin to help shift everything? So like you would give
Even if their albumin is less than 3.5, because the data on given albumin, and I can give 25%, but the data on given albumin, if their albumins are not less than 2.5, really doesn't show any benefit to them. Now, if they got hypotensive after I gave them the Lasix, and I'm in the ICU waiting to go to the OR, I might give them 25% albumin then.
Right.
Right, as a volume resuscitation,
but
so I
not
can
necessarily-
minimize my volume, give them 50 or 100 to 25% albumin. And I would give them calcium, because I always give calcium on givers. I'm a creature of habit. I just find that it's helpful and successful. All right, so this is what we saw when we did our original data collection. We saw that before we went to our donor management strategy, our mean airway pressures were sitting around 9. After we went to our donor management strategies, our mean airway pressures were around 16. What we saw before we started our recruitment strategies, and our PF ratios at the end were around 300. They weren't bad, but they went up to around 450 when we did our recruitment strategy. So then we asked ourselves, what did that mean and what did it actually translate? So these are the years before. So we did this study in 2009. So these are the 4 years before. And you can see that we were running right around the national average of about 20% of our donors were lung donors. And we jumped up to about doubling that. We got about 40% of our donors were lung donors after that. And this is all donors. Okay, all brain dead donors. And we saw that our total lungs transplanted went up to 84 from the year before it was 28, but it also about doubled. And then we were concerned about whether this was adversely affecting our other organs. And we actually demonstrated that all of our organs went up because we were just doing better overall donor management, we felt like. And so we saw our O to E go from 2.8 to 3.5, and all of our other organs increased in utility. So the conclusions of this were that aggressive lung donor protocol resulted in about a 200% increase in local organ donors that were lung donors, and about a 300% increase in local lungs transplanted, with no difference in the lung recipient outcomes. And the way we did this is the majority of our lungs went to the Cleveland Clinic. So we compared all of the lungs they got from us to all of the lungs that they transplanted from outside. And we compared the 2 cohorts to see if there was any difference in the outcomes. And we found there was no difference in the outcomes up to 5 years out. So we felt like this should, because at the time when we were doing this, almost nobody else was doing this lung donor management strategy. So all of these outside lungs that we looked at, they were not being done with this kind of management strategy. So that's how we compared it. And we demonstrated that we had a non-inferiority at out to 5 years in survival in terms of recipients. So this became sort of our normal pattern, and ever since then, we've kind of about between 30, I would say about 35 to 40% of our donors on an annual basis are lung donors. And our ODE for lungs, our latest was, well, this was last month or 2 months ago, was around 1.8. It was a little higher for it. This depends. It varies month to month, but our ODE for lungs was somewhere around 1.8. So I went to a second OPO where they were having lung donor problems, and we did the same kind of thing. And we had, well, this doesn't have like that. Oh yeah, this does have. So this was the second. This was when I did some consulting back in 2015, and they were around 10% of their donors were lung donors, 9% or 10%, and we got them up to about 22%. And we took their ODE in a year of doing this from, it was 0.4 and it went up to 0.9. So they were a really poor performing lung transplant center, and they got to be about an average performing lung transplant center implementing this protocol. So that was the second OPO. And then the third OPO was the work that I've done with our legacy, and we implemented this a couple of years ago. And we actually were seeing a significant increase until the COVID hit in 2021. And then the lungs per donor went down from 0.53 down to 0.4. Because, again, this wasn't because of the lung donor management, but I think it was because of the COVID and nobody was transplanting COVID positive lungs. But we're back on track doing more lungs there now. So this is the result of this first case that we talked about. Initially, we changed the ventilator to pressure control. We went from an IDE of 1, we went to an IDE of 1 to 1. We took the PEEP up of 10-10. And then we went out to pressure control inverse ratio to a 7 to 1 with a P high of 24 and a P low of 0, a T high of 4.5 and a T low of 0.7. And we targeted 8 per kilo of tidal volume. This is the initial X-ray. This is the following X-ray. We then went out, we gave the patient initially fluid resuscitation and steroids, and then we diurese, because sometimes you have to give them fluid up front, then diurese. And you can see the lungs on the right-hand side down at the bottom and how much clearer they look. Day 6, the patient, so this was the third day that we've been managing. The 6th day the patient had been in the ICU. We were out on extreme pressure control inverse ratio out to a 10 to 1. We had improving chest X-rays and ABGs. Our PF ratio was 550 on 1 to 1 PEEP of 5 tidal volume of 8 per kilo, and we were ready to make lung offers. So the most important thing now is continue management and hope the PF ratio continues. Return to VCAC 8 per kilo PEEP of 5, continue on 100% FiO2, get the transplant surgeons to come to the OR to look at the lungs, or continue recruitment approach until the lungs are recovered. And obviously we got to get the transplant surgeons there, and they were happy to come for these lungs, and these lungs got transplanted.
Is that day 6 admit or day 6 of on case?
Day 6 of admission to the ICU, day 3 of management for us. So 3 days is not uncommon for us. And again, I would tell you that if you're going to do aggressive lung recruitment, it takes time. And I think that not only do you recover more lungs, but you recover more hearts, you recover more kidneys, you recover more livers. So I think the extra 24 hours may be worth it. I mean, we had an average case rate of, I mean, we were around 36 to 40 hours average before, and I think we went out to about 48 hours to 50 hours after. So we've increased our average case rate by a bit, but not that much. And the benefits have been, you know, far outweighed.
Sorry, you might have already addressed this, but like what point are you basically saying that it's not going to work? If it's not.
So if I get out to a pressure control inverse ratio of an 8 or 10 to 1, and I prone them and my blood gases just aren't moving, then I'm done. I mean, you know, if you can't get your targets, you can't get your targets. You can only do so much.
Okay. So if there's any kind of improvement at all, you would still
I'll
continue.
keep working on it.
Okay.
You know, I make sure my fluid balance is okay. I'll try to diurese them a little bit more. Sometimes I'll try to give them a little bit higher blood pressure to try to get a little bit more fluid off that way. As long as it's not injuring the other organs and I've got good oxygenation, good oxygen delivery, and all my other numbers are improving, then I'll continue to work on the lungs. I mean, there have been lungs that I've worked on for, 24 hours longer than I've worked on all the other organs. They take longer. And it's just the way it goes. If you want to get them, you gotta take your time with them. As long as they're making improvement.
I think the thing that I've been seeing is we'll be improving slightly, but not enough to like be for sure we're going to transplant lungs. But in the meantime, our creatinine is going from like it's elevated creatinine to it keeps getting worse and worse.
And then you gotta sometimes make your calls, right? I mean, that's where you gotta take into account the fluid balance. But again, to me, the idea is to get going quickly on your recruitment, not to wait for, I mean, if you don't go into APRB until 36 hours out, you're kicking yourself in the, in your own foot. I mean, I want to be in APRB if I need to be. I want to be in it 6 to 12 hours after I'm on site. I mean, and that way I've got a good 24 hours, 36 hours before I'm at my 40 hours, right? So that's the whole key in all this is to move quickly. And that's why you have to have that strategy and you have to have that approach. So, I mean, my folks get on site before they do anything else, before they even call us to do a huddle, they're given a fluid bolus and they're going to pressure control, mode of ventilation, they're going to an IDE of 1-to-1 and increasing the PEEP up to 8. And if they're hemodynamically tolerated, they may already increased up to 10 before they call me. And that's within 4 hours of being on site. Is the way we set it up. Now, that's just what we did. But everybody has to do their own thing. You have to decide how you want to work, and you've got to talk to your own folks. But this is another case. This was a pediatric donor, was 7 years old, 42 kilos, struck by a truck, bad head injury, chest injury, abdominal injuries, was declared brain dead at 72 hours. The initial settings on this were SIM-VC with 100% oxygen, PEEP of 6, tidal volume of 250, respiratory rate of 30, and then with that had a PF ratio of 47 with a pH of 726 and a CO2 of 49. So what do you do now? I mean, you recheck your blood gas in 4 hours, you increase your FiO2, you perform recruitment maneuvers and increase your MAP, or the lungs are trash, just focus on the abdominals. And I mean, obviously what we do is we do C. You could do D. A lot of people know, I'm telling you, you see this blood gas on 100% oxygen, a PEEP of 7 or 6, and you've got a PF ratio of 47. A lot of people are like, we're done. We can't go to the OR.
I mean, I think if you had asked us a year ago what we would have done and
Yeah.
now is two different things. I
Yeah.
think we're all aspiration pneumonia versus just,
Yeah. So what we did was we did C. And the most effective way to improve oxygenation is going to be to increase the tidal volume, increase the mean airway pressure, leave the FiO2 at 100% weight, give diuretics, or give sodium bicarbonate. And the answer is obviously increase the mean airway pressure. I hope you all knew that. Okay. And the best way to reduce the PCO2 will be to do what? Increase your tidal volume to 15 per kilo, increase your rate, increase your PEEP, give sodium bicarbonate, wait, and repeat your blood gas in 4 hours.
Right.
Yeah, so because we're doing the other recruitment maneuvers, I just say just wait, because you're going to recruit better, and then you're going to be exchanging better. And then what tidal volume do you do? 6 to 8 per kilo. And this was our original, so we were on 55% oxygen, PEEP of 5, PIP of 30, respiratory rate of 24, and an IDE ratio of 3-to-1. This is when we used to do 3-to-1. We used to do 1-to-1, 2-to-1, 3-to-1, and then go to APRB. Then we just started going 1-to-1, 2-to-1 APRB. It's just cleaner and easier, and you don't have to worry about too much autographing. So this we did a 3-to-1 in this one, and with the 3-to-1, our PF ratio was up to 247. And then what would you do now? I told you to forget about the lungs and get to the OR already. Continue current management, recheck, recruitment maneuvers, and recheck. Trial of high frequency oscillator or trial of extreme pressure control. This is what we're here for, so that's what we did. And then the other measures you can do are prone positioning. You can do advanced modes. We talked about that. And this is what subsequently happened. So we got our PF ratio. We were up to 100%, P high of 33, P low of 0, T high of 5.5, and T low of 0.5. So an 11-to-1 inverse ratio. And our PF ratio went up to 518. The lungs cleared and they got transplanted. So, I mean, this is just a couple of examples of cases and how we did things. So basically the principles of management are an aggressive tier ventilator strategy. We take everybody from volume control to pressure control, the pressure control inverse ratio, and then out to extreme if we need to. We do PEEP recruitment maneuvers until we're up to the either pressure control inverse ratio or extreme. We inflate the cuff to 25. We elevate the head at bed 30 degrees. We do chest physiotherapy, suctioning closed systems. We do bronchodilators, steroids, ABGs. And the only thing I would add to this is prone positioning. And if I get to the point where if I'm on my pressure control, I'm on a PEEP of 12, my PF ratios are still, and an IDE of 1-to-1, and my PF ratios are still not improving, I'll prone them then. And then if I need to, then I'll go out to APRB, but I'll prone them first and wait an hour or two and see what the results of proning are. And if I still don't have the effect that I want, then I'll go ahead and put them in APRB when they're proned. I have no problem with that.
And you usually do 12 and 12.
12 and 12 proning, yes. If I can get away with 18 and 6 or 20 and 4, I'll do that, but usually it's 12 and 12. Usually I prone when the family's not
We're
there.
going to make so many friends in the hospital.
Well, they're so used to doing it now with the. And a lot of them have these teams that'll do it, right?
You should come. Orlando does. I worked at Orlando. They had a great proning team, but I think Oklahoma, we're not, I mean, we prone, but they don't have a lot of proning teams here.
Well, but they have a proning protocol. They have.
Yeah, they don't have, yeah, they have to have a team.
So, I mean, those are the things that do get done. And, you know, the bottom line is you take your time, but you don't take too much time. And that you have to just look and see what the results are. And so these are my closing words, and that is that remember, ventilators don't oxygenate and ventilate. They just push gas, then they stop, then they recycle. How they push, what gas, how many cycles per minute, what flow rate, for how long, to reach what end target is controlled by the operator. And that means the ventilator is only as smart as we are about how to use it. And so we have to be pretty smart about how to use it. I think we have the potential to easily double the number of lungs that we donate. And we can eliminate, if every OPO doubled the number of lungs they recover in transplant in a year, the lung list would be gone. It'd eliminate the lung list. But I think OPOs have to be in collaboration with their donor hospitals. Transplant centers need to treat every donor as a potential lung donor. And we need to utilize a consistent, aggressive lung donor management protocol that, in my opinion, should incorporate pressure control inverse ratio ventilation. I think sharing perspectives works. And you can see my last two pictures. Right-hand side, there's what? Duck and a rabbit. It's Easter, so there's the rabbit picture. And on the right-hand side, what do you see on the right-hand side?
Is that a holiday here?
Girl.
There's an old woman and a young girl. So there's an old woman that's got sort of a side profile, and then there's a young girl that's kind of facing the wearing a bonnet under it. That's an Easter bonnet for you.
Okay.
Just for you.
Just really hungry.
It's almost 12 o'clock. I got done by 12. I think that's pretty good. So sharing perspectives works. All donors are potential lung donors until proven otherwise. Use a protocolized strategy where you're trying to maximize lung donor yield while limiting ventilator-associated lung injury. We're all in this together. You've got to communicate between the ICU, the OPO, and the transplant teams. PF ratio greater than 300 is what gets the surgeon to the OR to see the lungs. And you can't recover lungs without a transplant surgeon. And then the science of donation and donor management is tied to recipient outcomes, and it's still critical for this field. And then have a lovely night. We got done before lunch.